Hey, everybody, welcome back into another edition of the Dental Trade Alliance podcast powered by the DTA. My name is Kevin Henry. I'm thrilled to be the host of this podcast, and I'm also thrilled to welcome back Lauren Seno. Lauren, how are you?
I'm doing pretty good. How are you this morning?
Doing well. Great to see you, and appreciate your time today.
Yeah, I'm excited to be back.
Well, Lauren is with Charm Economics, and Charm just completed the medical dental integration update with the Dental Trade Alliance, and there will be a link to that in the show notes. But before we dive in, Lauren, just love for audience to know a little bit more about you and Charm Economics.
Yeah, so Charm Economics, we are a group of health economists. We do research for a number of different trade association, different groups within the healthcare industry, including with the Dental Trade Alliance. And over the last year, we've been working on a couple of different projects with them. I think the last time, Kevin, you and I spoke, we were talking about the survey that we did earlier in the year, and we got some really amazing data from that. And then what we focused on for the second half of the year was what we're going to talk about today, which is this medical dental integration update. And part and parcel with medical dental integration is that, what's going on in the policy landscape, because what's happening in terms of a policy decision making is what's really driving a lot of potential integration between, the medical side of the house and the dental side of the house, which historically have been separate, but, we're starting to see some at least desire for that to come together a little bit more.
So, whenever it comes to this paper, what's the big picture story that you're wanting to get across about what's going on in the dental industry?
Yeah, like so many things, especially in the policy landscape, we're sort of seeing a little bit of a paradox in dental care policy. So, on the one hand, there are some really positive developments. Like, for example, Health and Human Services, or HHS, is allowing adult dental benefits in marketplace plans starting in 2027. So the marketplace plans are those, Affordable Care Act plans, ones that you can buy outside of your employer and sponsored insurance. And historically, those were not allowed to include dental benefits. They had to either be standalone plans or, something completely separate. Starting in 2027, they're going to be allowed to integrate dental plans into the medical plans in the marketplace. So that's, really big news. Medicare is covering dental for dialysis patients. That's another positive development. So it's really, anybody who's working in the dental field knows there's a really strong connection between oral health and patients with diabetes or kidney and, all kinds of endocrine issues. So that's a good first step in, getting coverage for those Medicare patients who are on dialysis. And then there's going to be stronger tracking of medical dental integration. We'll talk about that a little bit later, the KX modifier, but those are kind of the three big in the sort of tailwinds, let's just say, in terms of pushing medical dental integration forward. We have some headwinds as well, which is that from a policy perspective, we're likely to see, and I think we've already seen, we wrote this paper in December and, early returns are coming in on what's changing in terms of marketplace or ACA plan enrollment. And some of the policy changes that were made last year are leading to people leaving coverage. And so less people are going to be insured. That's how we're tracking that is through medical insurance, but most folks who do not carry medical insurance are not going to be carrying dental insurance as well. So a coverage loss in one area is likely to lead to a coverage loss in the other area. And so that's kind of one of the bigger ones. And then we also have tariffs. We'll unpack a little bit more about tariffs and how they impact medical care in general. But that's another thing that is likely going to have a little bit of a headwind against demand and utilization across all of healthcare, but also in dental.
You mentioned those headwinds, and one of the things that it talks about in the paper is that the dental benefits are often the first on the chopping block whenever it comes to any kind of state budget crisis. So why is that, and what does history kind of tell us about that as well?
Yeah. So one of the primary differences between a state government and the federal government is that states are required to have a balanced budget and the federal government is not. And at the end of the year. And so when states are facing budget crises, they only have a handful of levers that they can pull in order to decrease spending. And what we have seen is that when states are facing fiscal pressure, things within the Medicaid world start to get pulled back. And one of the first things to get pulled back is dental coverage. We saw that over time, states have ebbed and flowed in terms of whether or not Medicaid covers dental. But we know that when that happens, so we have one example that we talked about in the paper with California, when they suspended their adult benefit line, emergency department visits for dental conditions jumped by over 30% because people couldn't access preventive care. And so we know that as states are starting to think about what's going on in their budgets, they're going to probably start to eye changes to Medicaid one of the first things that they do in Medicaid is to pull back dental coverage. And when that happens, there's higher utilization of emergency care. And so that may divert some care out of dental offices into EDs. It will, put some pressure on dental offices because they may be doing less preventive care because patients don't have that upfront coverage. And so they wait until it's a really big problem and then they end up in the ED. So that's part of it. And what's driving, to kind of take a step back, I realize I kind of skipped that, is what's driving these state budget pressures. And there's a handful of things that are going on at the federal level that's kind of pushing some of the fiscal pressure down onto states. But one is the prohibition on states using provider taxes to fund Medicaid. This has kind of always been a strange policy situation in which the states would tax the providers that collect money and then take that tax money and then use it to pay the providers. It was kind of a strange circular pattern. But what it did do was that it bolstered a lot of funding for Medicaid. And so now that prohibition is going into place, it is going to put that pressure on those Medicaid programs.
You teased tariffs a minute ago, so I got to ask, how are Section 301 tariffs on dental supplies affecting the industry?
Yeah. So the Section 301 tariffs, and when we talk about tariffs, like these are changing every day. So it's important to note that anything could change. But when we're talking sort of broadly, tariffs, especially on goods that are made, goods that are made abroad, and especially things that are sole source or, limited source. So for example, we've talked to folks in the industry, there are a handful of areas, maybe it's China, maybe it's Germany, maybe it's Japan, where those are kind of the three areas where dental providers are getting a lot of supplies. And in some cases, they're sole source. So they're only being made in Japan or they're only being made in Germany. And when there is a tariff with those countries, anything that's coming in is going to have a higher import duty. So you're going to have to pay more to get the same products, essentially. And when that happens, there's two options. The purchaser can eat the cost or they can pass it on to their consumer, which in this case would be the patient. And so suppliers and folks who are purchasing these supplies are kind of in a tough spot where they have to decide, okay, well, where are we going to shift the cost? And typically utilization of dental services is pretty elastic in the sense that when prices change, people change their behaviors. They go elsewhere, whether that is to a different dentist's office or they go or they forego care entirely. So it has an effect on kind of the demand side of things if they're passing the costs on to patients. And if they're not, then it's increasing overhead. And so folks who are purchasers of products that are tariffed are in kind of a tough spot, especially when they're single or sole source. Obviously, that's not the case when you can onshore the production of those products. So instead of it being made in China or Japan, we're making it here in the United States. So we might start to see some shifts in where folks are getting products from that might be more focused on things that are from non-tariffed countries or that are sourced within the United States.
You mentioned the KX modifier a few minutes ago, and I'm curious, dive into that a little bit more and why does it matter?
Yeah. So the KX modifier, and these modifiers are sort of a funny thing in healthcare billing, but it's essentially an add-on code that gets attached onto the billing of certain services. And in this case, the KX modifier is for any dental service that is, and I'll put it in quotes because this is the language of the regulation, is that it's inextricably linked to a covered medical condition. So for example, if you are doing care on a patient who has periodontal disease that is inextricably linked to their diabetes, then they would want to use this KX modifier. And that KX modifier just essentially says, this is a service that is in relation to a medical condition. And that is important because it supports the idea and the tracking of medical dental integration. The more that these KX modifier codes show up in the claims, the more it is kind of proving the point that medical and dental care are interconnected and that it's something that could potentially have higher reimbursement down in the future. And so right now it's more of an infrastructure thing. It's a tracking mechanism to see what the volume of services and codes are that are, dental care that is inextricably linked to medical care. And it's a positive step in terms of bolstering that idea that those two things are connected. And it could potentially lead to future, the foundation for future integrated care models. Potentially new reimbursement structures. This is kind of a data collection phase, but usually data is collected and then we would hope for it to be acted on. And I think that that would be the case here if we can start to see a tighter connection between medical and dental care, as now shown by this KX modifier code.
So I feel like we've talked a few of the headwinds and the maybe negatives. So what are some of the positives or opportunities that you're seeing out there? Let's flip it on its head.
Yeah. So I think, it builds on this idea of the KX modifier and sort of a serious look at the interconnectedness of medical and dental care. I think in general, there is the conversation around sort of health span and health as a component of wellness and aging. And so I think that that is a good umbrella for talking about the fact that we're thinking about whole body care. And I think for so long, the mouth has been like divorced from the body when we've been talking a lot about care. And you would hope that, all the conversation around wellness, around health span would kind of put the mouth back in the body as part of, whole person care. So I think the KX modifier is like a very interesting policy change that kind of puts some weight behind that idea. The ESRD dental coverage change that we talked about at the beginning, that's another one that is acknowledging that there's a cause and effect between what's happening in the body, in the mouth, and vice versa. And then the last thing that I'll mention too is that within the 2026 Medicare physician fee schedule, so this is the kind of broad fee schedule that determines how doctors are paid, that there's enhanced primary care payments that would include things like oral health screening. And so to the extent that there is dollars being put behind more primary care activities, I think that's only a good thing when it comes to oral health. And so that's something that is in place already that is saying physicians are going to be paid in the primary care setting to do more comprehensive care. That should include oral health care screenings. The other thing that I'll mention in terms of opportunity is, for providers and companies, whether those are suppliers, that can position themselves as sort of like integrated care delivery systems, like those who can facilitate conversations with the medical side of the house. Maybe they're able to talk to their physicians. The dental side is able to talk to their physicians, or there are products and services that are facilitating those conversations. I think that that's a big opportunity in the market. And so while there is going to be a little bit of market tightness around the tariffs and around maybe potentially decreasing demand because of some coverage changes, there's a big opportunity for those who can kind of step in and say, okay, well, we can do this in a different way. We can do this really well. And I think how to do it really well right now, at least in terms of the market signals, is on facilitating that greater integration between the medical and the dental side of things.
Lauren, I appreciate the deep dive into this. And I know that there will probably be some questions that come up from this. How's the way to get a hold of you and maybe learn more about charm economics as well?
Yeah. Yes. We love to talk about this stuff. We write all of these papers and you tell from today, like I just have like a ton of stuff I want to talk about. So I'm happy to talk to you about it. So you can go to our website, it's charmeconomics.com, or you can email me directly. You can just do Lauren at Charm Economics. Very happy to talk more about it and some of the research that we've been doing.
And all that'll be in the show notes. So easy for you to find if you want to check out some things from Charm, as well as reach Lauren to ask a little bit more than we got into today on the podcast. But Lauren, it's always good to see you, and I really appreciate the time. Thank you so much.
Thank you, Kevin.
Absolutely. And thanks to all of you for listening to this episode of the Dental Trade Alliance podcast, again, powered by the DTA. We'll be back soon with another episode. Until then, it's Kevin Henry, host of the podcast, signing off. And as always, wish you nothing but success ahead.